this is a great case. So this is a 73-year-old woman who presents for screening mammogram. She's had a history of a bunch of abnormal mammograms, okay? So this is 2016. You see the cyst here. Okay, she was worked up for a cyst. She was called back for calcifications. These calcifications, faint calcifications, which were called benign in 2016, and she was given a BI-RADS 2. She proceeded to come to our clinic, and in 2018, you can kind of see this cyst here. 2019, it seems a little bit smaller. 2020 screen, you can kind of see something here, but you know, it's dense tissue. These were all read as BI-RADS 2 negative. I'd have to agree. That's what I'd read it as. 2020, still read as BI-RADS 2. This is a 2021 2D image. Doesn't look that concerning. This area looks stable. So in 2021, I was about to, this area looks stable. It's been there since 2016. I was about to read it BI-RADS 2. But then you get the case score again. The case score says a 77, and the lesion score was 57. You look at it a little bit longer, you realize it's dense, has some margins. You knew you had a cyst there and it's stable. So part of you wants to use the stability card and say, this thing's stable. Why would I call this back? The other part of you says, okay, there's a high case score. Maybe I should reevaluate this. It's been a while, but this lady's had a bunch of abnormal mammograms subconsciously at some level. I know it's not accurate, but if you've had a patient with a bunch of abnormal mammograms, I at least try to just move them through. Come on, let's not give them another diagnostic. Let's not make them pay that bill. There's a lot of reason to want to call something stable and undercall in that circumstance, at least for me. But because of the imaging score, we said, okay, let's call this back. On the MLO, I don't know, maybe there's supervision out there. I see nothing. There's nothing I'd call back, right? And so we proceeded to ultrasound. I mean, we proceeded to diagnostics. You can see on the spot MLO, there's nothing I'd call. On the spot CC, you start to see an irregular mass looking. This doesn't look like a cyst, right? So we proceeded to ultrasound, and we saw two things. So full disclosure, I didn't do the ultrasound workup. I probably wouldn't have called this back at 12. There was something at 12 they recommended biopsy for. That doesn't stand out to me on the pictures, but we all know real-time sonography is a little bit different, right? So there's something that's stuck out in this area that they called back as abnormal. And then they found this mass, a 7-millimeter mass at 1 o'clock that matched that area of abnormality. There was no cyst here. And so patient went to get a biopsy of both sites. This site came back benign, fibrocystic. This came back as an invasive lobular. So for those of you that aren't breast imagers, invasive lobular is about 15% of breast cancer, and it's sneaky. They grow in sheets, they spread quickly, they keep us very humble, and they can spread rapidly. They typically present as distortion on one view, which occurred in this case. So what was the lesson here? And if you see on the post biopsy imaging, that's exactly what the algorithm flagged, and it was an invasive lobular hanging out there. This is a 2021 screening mammogram. So what we think happened is the cyst actually resorbed, which is a normal phenomenon. A cyst kind of goes away, but in its place grew a cancer, not because of the cyst, but it was two things going on at once. That's a sneaky problem. You know, a space occupying lesion, you don't think of it being replaced by another space occupying lesion. That's a pretty subtle problem to happen. And in those circumstances, especially, it's really nice to have an algorithm to kind of re-guide you that, hey, the imaging features of this area are abnormal. I would have very easily called this stable just because there was fullness there in previous years. The patients had a bunch of abnormal mammograms. You want to try to be reasonable. You want to try to be practical. But at the same time, to have an arbiter that's just looks at every pixel and compares it to a cancer database says, hey, there's something you need to look at here. And that's all it's saying. I looked at that. It tipped me over. We caught a small invasive lobular early because of this. Huge benefit. These kinds of cases happen all the time. We all know there are plenty of patients with lots of cysts, and all of you have probably seen cancers in between cysts. There are messy kind of situations that we're left to sort out. We need software like this. We need solutions like this to help us catch little spots of cancer that we may overlook for various reasons.